Welcome everyone to our education session this afternoon titled Diversity and Inclusion, Fostering Cultural Competence in Practice. My name is Annette Johns and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador Association of Social Workers. I'll be co-moderating the panel this afternoon along with my colleague Peggy Rauman, Nursing Consultant Policy and Practice with the Association of Registered Nurses, Newfoundland and Labrador. This year marks the 16th anniversary of our collaboration to host this education event for healthcare professionals. Can't believe where the last 16 years have gone. So today's session is being offered on site from the Health Sciences Centre main auditorium and by live webcast. While this event is organized by the NLASW and the ARNNL, we would like to acknowledge the College of Licensed Practical Nurses, Newfoundland and Labrador, who has partnered with us to bring you this event today. We would also like to thank the Munn School of Social Work for their support and to staff from the Centre for Innovation, Teaching and Learning with Munn, who are here with us today and broadcasting this event in real time. This session is being video recorded and will be made available on the websites of our professional associations for future viewing. So we do have a tight time schedule for today's session, and we're going to begin with a presentation from each of our panelists, and there will be an opportunity at the end for clarifying questions on the material that's presented. We ask that you keep your questions succinct and with the understanding that the information is being recorded. For those attending by webinar, please email your questions to educationwebcast2019@gmail.com. We will have microphones for those in the room to ask questions during the designated question period. The focus and content of today's session is meant to encourage reflection and dialogue, and you must consider the material presented within the context of your own practice. As healthcare professionals, we are dedicated to providing people with the highest quality services, enhancing our knowledge, skills, and abilities, and engaging in ethical practice. Respect for diversity is a fundamental aspect of our work, and we have a responsibility to ensure that cultural awareness, in its broadest sense, is integrated into our work with individuals, families, and communities. We challenge social injustices, discrimination, racism, and all the other isms, but what does it mean to be truly competent in practice? We have 4 stellar panelists joining us for the presentation today, and each brings tremendous knowledge and expertise on this topic. They will highlight some of the cultural considerations within our provincial context, offer input into what healthcare professionals can consider in their assessments and interventions, and highlight some initiatives to foster cultural competence. As you listen to the panel presentations, I want you just to consider the following reflective questions. What cultures do I identify with? Do I express my culture to others? What impact does culture have on my personal life, my work life? How can I engage effectively in a culture different with people in a culture different than my own? How can I continue to foster cultural competence in my practice? And how can I advocate for change towards cultural competence at an organizational and systems level? In May of 2016, the Newfoundland and Labrador Association of Social Workers released standards for cultural competence in social work practice. These standards highlight practice considerations, ethical responsibilities, and continuing education guidelines for fostering culturally competent practice and promoting cultural competence as an integral component of practice. While developed for social workers, the ethical standards can be used by other healthcare professionals in their work. And in the standards, it's acknowledged that many definitions of cultural competence exist, yet we really see this as an umbrella term for the knowledge and skills required when working within the cultural context of clients. It incorporates cultural sensitivity, awareness, humility, and safety. As healthcare professionals, we are not expected to be experts in every culture, but we do have a responsibility to be aware of the cultural realities and experiences our clients bring to us, and how our culture has shaped us as individuals and professionals. We must seek and avail of opportunities to enhance our knowledge, skills, and abilities in working with diverse cultures, foster working environments where discussions on culture happen in meaningful, respectful, and purposeful ways, and use our leadership skills to engage in policy development as opportunities arise. Cultural competence is not an endpoint, but a journey built on respect, collaboration, learning, reflection, and professional growth. And in keeping with this theme, I now want to introduce our panelists in order of their respective presentations. I'll begin with Molly on my far closest to my left. Molly Butler is a registered nurse and the Regional Director of Professional Practice and Indigenous Health with Eastern Health. After living away from the province, Molly returned in 2011 to take on the role of Professional Practice Nursing Director with Eastern Health. In 2014, her role expanded to include 10 other professions, and in 2016, she agreed to add Indigenous Health to her portfolio. Molly has worked in 4 Canadian provinces and internationally. Her professional grounding is nursing, and she has a master's in public health administration from the University of Victoria. While living abroad, Molly completed her Doctor of Philosophy in Higher Education through the University of Stellenbosch in South Africa, with a focus on professional development. Molly's professional experience includes clinical management and professional governance. So welcome, Molly. I'll now introduce Katie Digger. Katie is a senior Aboriginal patient navigator with Eastern Health. Katie has been an Aboriginal patient navigator since June of 2009, and she helped create the Aboriginal Patient Navigator program. Before moving to St. John's, Katie worked with Labrador Grenfell Health in Nain for 14 years, 8 years as a full-time personal care attendant, and 6 years as a bookkeeping clerk. So welcome, Katie. And next to Katie, we have Jim Olford. Jim is a social worker with 30 years experience in child and adolescent mental health. He works at the Janeway Family Centre, primarily with adults and families. Jim has been involved in the development and delivery of many groups, including empowerment groups for youth from refugee backgrounds. He has a career-long interest in social justice and working with trauma. Jim has a BA and a Bachelor of Social Work from Memorial and a Master of Social Work from the University of Toronto. He completed a certificate in global mental health from Harvard in 2015. So welcome, Jim. And last but not least, we have Rob Sinnott. Rob has been practicing social work since the year 2000. He is a counselor with the Mental Health and Addictions Program at Eastern Health. He has played a role as co-chair of the Trans Health Committee with Eastern Health. As a volunteer, he helped create the LGBTQ youth group and Camp Eclipse Out in the Woods, a leadership retreat for LGBTQ youth, both through Planned Parenthood. He is past co-chair of PFLAG Canada St. John's chapter. He is a former board member of CPATH, which is the Canadian Professional Association for Transgender Health, and he remains a member of both CPATH and WPATH, which is the World Professional Association for Transgender Health. So what a wonderful panel, so much expertise and knowledge to share, and I now invite Peggy to come forward to begin the panel presentations.
Thank you, Annette. So my name is Peggy Rauman. I'm a nursing consultant for policy and practice with the Association of Registered Nurses in Newfoundland and Labrador. I just want to thank Annette for her introduction to this Education Day. I'm very much looking forward to the expertise that's going to be provided by this panel and the discussions at the end of today's sessions. So just remember, if you do have a question, just write it down so that at the end of today, then you can ask your question. I will now ask Molly Butler to come forth as the first panelist presenter. Molly's presentation is called Diversity is a Fact, Inclusion is a Choice, and Cultural Competence is a Professional Responsibility. So I'll get that up for you now. Okay, Molly, you can use this one, or you can use the mouse. It's up to you.
Just like to thank the Aaron and Nell and the Social Work Association for inviting me to be part of the panel. And it's been a pleasure to work with Annette and Peggy along the way, as well as my fellow colleagues. I'm going to talk today about, as Peggy already said, about professional responsibility for us to be culturally competent. I wanted to start, though, with when you look at cultural competency, diversity and inclusion and cultural competency, it's a huge, big portfolio of information. And as you can gather from here, we've got a lot of diversity in Newfoundland as well. We have in Newfoundland been more diverse probably than we really recognize. But in the past few years, we've had really three different countries coming to Canada more than anybody else. It kind of surprised me when I looked at it. In 2015, the Philippines were the top group, and Syria and China were next. So we've welcomed quite a number of immigrants. But Indigenous people are recognized for their heritage slowly, and we're really starting to look at it more seriously, and I really wanted to focus on Indigenous peoples today in my presentation. And of course, inclusion, when we look at it, is a meaning, having access and choices about how we participate in all aspects of human rights and fundamental freedoms. So it really gets down to who we are as people and our human rights, and helping everybody to be able to express their human rights. Today, what I want to do is illustrate then some of our historical decisions that have continued to influence the social determinants of health and health outcomes for all of us, but particularly Indigenous Canadians. I want to reflect on steps being taken and actions that are being taken as well to become more culturally competent, and then discuss how we as health professionals, I'm kind of short here, discuss how a cultural competency relates to our practice. So I just want to give, I have an education background, so I really think it's important for all of us to have the same meaning when we talk about words. And for my presentation, culture represents patterns of being for a group of people, how groups of people believe, think, and act. Competence then describes the ability to do the right thing successfully and to do it successfully. It requires us to have knowledge, skills, abilities, behavior, and of course attitudes, as well as making judgments. And last but not least, cultural competence means to know and behave in a way that respects and honors the beliefs of others. Society's understanding of this concept, of course, evolves over time. When I was looking in the literature, Cross's cultural competency framework really struck me, because what he did in the 1980s, he started with cultural destruction and looked then at cultural capacity, blindness, pre-contemplative competence, and cultural proficiency. So the words are a little bit different than what we're using today, but I thought it was an interesting way to start, because if you think about what happened in particular to our Indigenous peoples, there was a lot of destruction, and it still affects us to this very day, and I will illustrate that as I go along. A cultural competency system then requires all of us to acknowledge the importance of culture, and to be able to assess culture in our work, and be vigilant about how we use that knowledge and how we use it in our practice. Most negative ends of the continuum, of course, is the destructive piece. And it takes us a while to kind of move forward. And it's not that we're all completely arriving at a place where we're culturally proficient. Every day we're learning something. This is another framework that shows the culture as not necessary somewhere you arrive being a destiny. And Annette talked about cultural awareness, and this is where we start from usually, to be aware of differences in culture and to seek broader context of our understanding. But staying at cultural awareness is not enough as health professionals. We have not only to become more culturally sensitive and recognize and accept that there are different ways of knowing in the world and integrate some of that knowing in our practice, but we have to move towards cultural competence. We're required as health professionals to do that. And of course, more and more we're talking about cultural humility. and that it being a lifelong commitment to being self-evaluating our practice and making sure that we're readdressing the powers of imbalance. So then culture is a lens through which each of us see our world. And some of us will see the world, and depending on what we're doing, individualistically. So we'll work with one person, say, to address their health needs. But other people see the world in a collective worldview. And I'll illustrate that in a moment with a few pictures. But I also wanted to stress the fact again that it's a set of values and beliefs we're talking about. And it also has a lot of social, historical, economic, as well as political context surrounding how culture is viewed. This diagram that was created by Dr. Mark Dockstader is an illustration of how, when Canada was formed in 1870, how it started with Indigenous people having no rights. Right up to the days where in 2015, where we had the Truth and Reconciliation, and Justice Sinclair carried through that examination and did a lot of work to illustrate how residential schools in particular really did a lot of destructive things to Indigenous peoples. And we'll speak to that in a minute because it has the call for actions from the Truth and Reconciliation really has a lot to say to us as health professionals. And of course, you could spend a lot of time really examining all of these aspects historically, but we don't really have that much time to do that. But I would, the slides will be available to you if you need to look more closely at it. This is a picture that I found through my search as well, and it really looks at an individual trying to climb out of that destructive place. And the things that are said to people to keep them, push them back. And I'll give you an illustration of that in a case study in a minute. But at the bottom in the cultural destruction, calling people drunk and refusing to treat them because they think you're drunk without really examining them is a really good example of how Indigenous people have been treated. And there's lots of literature and poignant examples of that. And as you go up, looking at what is the problem and treating everybody the same, which is, of course, everybody is not the same. Going another step further up, looking at the training that we should get to be about Aboriginal people and other people, and sort of looking at them as the same. So we're not really looking differently at individual people still. And going then up to the culture pre-contemplative, where you think that Aboriginal perspective, you understand it, and you're starting to learn more about it. And then you start to recognize that there are certain things, cultural practices, that you need to be bearing in mind. And then coming up to the safety, of course, it takes a lot of work to get there. It's not a ladder that you can climb easily. And I think Katie will illustrate some of that from her experience in a minute. The example I wanted to talk about is one of legacy of Brian Sinclair. And it will show us how history actually still, to this very day, affects how we see the world. In September 19th of 2008, Brian entered the emergency unit in a hospital in Winnipeg. He was 45, and he had urinary tract infection. He was left unattended in the waiting room for 34 hours when another patient told a security guard that Brian was dead. Brian didn't receive any care the whole time he was in the emergency department because nobody recognized how ill he really was. He was seen in the emergency department frequently, was in a wheelchair because he had a double amputation. And he also was homeless and, of course, was Aboriginal. The family and others were convinced that Brian was treated the way he was because of racism. The interesting part about it, Brian's death sparked another professional, Dr. Marcia Dakota, to share her story of her father's, what happened to her father. Years ago, before Brian had died, Marcia was called into the emergency. Her father was in the emergency. She arrived and found him very distressed. He had been intubated, and nobody had sedated him. She was an internist and recognized what was happening for her father and took over his care. What had happened is he had a massive MI, and everybody was treating him thinking he was drunk and didn't know what was going on. Anyway, she got him sedated, and long story short, he's alive and well to this very day. But had she not been there, and had she not interjected in his care, he too would have been another Brian Sinclair. So I give you these stories to illustrate that these things are happening in today's world. And I'm sure Katie can share many more stories that are closer to home. So we're hearing more about these stories, and they're being used through the court system as well. And I could go on with another one. One of the things I would encourage you, though, is to listen to Brian Goldman's talk with Marcia Dakota, Dr. Dakota. She really tells a poignant story that will make you think about culture in a different way. I wanted to share with you some other statistics that's quite startling too, and that is the number of Indigenous children who've ended up in foster care over time. And as you can see from at the beginning of this slide, the children in care of 0 to 14 were only 7.7 for Aboriginal or Indigenous people. Today, though, in 2016, that number has crept up to well over half of kids of 0 to 4 that are in foster care. But it was interesting. A few weeks ago, there was a case, I think it was in Manitoba again, where a mother had a child and they took the child away. But people started speaking up for her, and they gave the child back to the family and put support in that family to help her. So we are changing, and I think I would encourage you not to be discouraged by what I'm saying, but these are some of the facts that we have to consider. So Justice Sinclair, in the Truth and Reconciliation Call to Action, said that he called upon all of us to become culturally competent. And one of the Truth and Reconciliation actions is to have cultural training and cultural competency. So reconciliation then includes acknowledging the wrongs of the past, knowing our true history, recognizing the inherent rights of all Indigenous people, and restoring a balance between Indigenous and non-Indigenous peoples. In the call to action, there's 94 of them, and they go well beyond the healthcare system. They go to education, to justice, to child welfare, churches, media, arts, and community. And I think you'll see a lot more voices of Indigenous people, even in Newfoundland and Labrador. If you take a trip down to Moomoo's Ice Cream, you'll look across and you'll see a mural on the wall that was created by Jordan Bennett from the west coast of the island. And Jordan has just won a prestigious award for his art recently. And so it's, more and more artists are showing their work as well in Newfoundland and Labrador, which is really exciting. And a few weeks ago, I had the pleasure of going to an opening at the Rooms, where a person from the West Coast, Nelson White, was given the first artist in resident for Indigenous people. So we're seeing more of the art being expressed, which is great. So you see here, too, the federal leadership is showing through, too. And I think the former minister, Jane Philpott, Dr. Jane Philpott, did a lot to progress and move things forward. And we hope that now that she's left that portfolio, that it will continue. So we're seeing more and more things happening through the federal legislation. I want to shift gears a little bit here to talk about and go back to get you back to your practice. First of all, though, I want to talk to how we see health. So the World Health Organization defines health, and this was in 1948, so it's a while ago, as a state of being of complete physical, mental, and social well-being, and not merely the absence of disease or infirmary. And then, of course, we've been really struggling with and trying to understand the social determinants of health, which gives us an even broader view of life, of health, rather. And it's that of being free of disease, but also having more control over chronic disease. And part of it is being influenced by the influence that we have over, the culture has over our health. And I want to show you health through an Indigenous lens. For us as Western non-Indigenous people, often we've come, although I have to say in Newfoundland we used to have a history more of collective viewpoints, more and more we see individual health. So we might put it into boxes and tackle one thing at a time, like gender and culture or social status or social support or whatever. But to address sort of some of the interactions that were happening. So this is more of where you have a stage of being pregnant to elder care. But I found this example from the Indigenous literature, and I thought, that helps us make a clearer picture and have a greater understanding of what it means to have social determinants of health influencing our health outcomes. And in the center of this diagram, as you can see, are children and families and communities. And surrounding that, you have all the determinants of health factors that must come into play to help us stay healthy, going from food security to social support to gender and to right out to the far sides of things with regards to more decision making that would be related to policies and priorities from our political scheme. Interestingly enough, things are looking up. In 2018, there was a survey done right across the country on Indigenous peoples, and there was from that survey, they said there's a strong sense of belonging and safety. So more and more Indigenous people feel that they belong and they are feeling safer. There's also children are having a stronger connection to their culture. The concerning part, though, is that youth are experiencing significant higher bullying. And primary health care access still is an issue for many Indigenous people throughout Canada. What is also concerning is that women, both youth and adults, have a significant higher rate of suicidal thoughts and suicidal attempts. And food insecurity is very alarming and an urgent health issue. So we're certainly not out of the water out of the bushes when it comes to some of the issues that need to be addressed for Indigenous people. And just this week there was a community in Northern Ontario, I believe it was, where the whole community had mold in its house, and they had to move kids and families out of their housing because of the degree of mold. Everybody was getting sick. So it's things that are still happening in today's world. So culture competency, then, some principles to guide our practice. As Annette already spoke about, it's really important for us to have respect for others, respect for diversity, and of course, human rights needs to be a factor in how we see cultural competence. We have to be acceptive, open, willing to learn new ways of being, and willing to search and find greater meaning. And knowledge and understanding is really critical as well. Then, of course, it's no good to have all this knowledge and understanding if we don't do something with it. So we have to internalize it, and importantly, we have to integrate it into the work that we do as health professionals. Katie will talk about this a lot more, but I just wanted to acknowledge that Eastern Health since 2008 has really focused on more and more on Indigenous health resources, and developed the Aboriginal Patient Navigator program that is quite well in its prime, and Katie will share more of that with you. I wanted to pause for a moment and ask you to self-reflect. So cultural competency, then, as I said, is not a place you arrive to, it's a journey. And think about yourself. Where do you think you fall on the cultural competency continuum? What steps would you take to move you forward? And here's a quick fact sheet that I won't have time to go over totally, but it gives you some ideas of where you think to judge where you fall on the continuum. And it's done in different colors. So you can get this later. So takeaway actions then. Consider the visible and the non-visible aspects of your own culture. Choose a culture other than your own and explore the perception of illness and health beliefs. I was really fortunate to have worked in Saudi Arabia for 8 years. And I learned so much about other people's culture. When I was there, I worked with 70 groups of nurses from 70 countries of nurses. And it was really fascinating how we had things in common, but we also had a lot of differences. And the worlds that other people see themselves through just sometimes was very perplexing, but you learn so much through that. So exploring culture competency then, think about it. We all have to do practice reviews. Why don't you include that in your practice review this year in your learning plan? So I wanted to summarize up by with a little quote that actually I found Katie. I'm stealing from Katie now. At the end of the day, when you look at culturally based services that respond to community identified needs, it comes down to people and ensuring that the people we provide services for get the most out of the time spent within the healthcare system. Think about that. And in closing, I want to quote a nurse leader, Jean Watson, who had the pleasure of meeting years ago. I think she's still alive, but she wrote a book on caring and nursing, she and M. Beavis. And Jean said, to care for somebody, I must know who I am. To care for somebody, I must know who the other is. To care for somebody, I must be able to bridge the gap between myself and the other. Thank you.
I'd just like to thank Molly for your presentation. You provided us with a lot of good information and a lot of things to reflect on. So I will introduce our next presenter. Let's see. And pull up the next slides. Our next presenter is Katie, and she's going to present on the Aboriginal Patient Navigator Program. So Katie, you can come up and I'll get your... And there you go.
Good afternoon. I'd like to thank Annette and Peggy for inviting me to come and speak with you today. I just want to make sure everybody could hear me loud and clear. So as Annette and Molly both said, I'm going to be speaking today about cultural safety in healthcare. I am the Senior Aboriginal Patient Navigator with the Aboriginal Patient Navigator Program. So I just wanted to start off with the goals of this session. After this session, participants should have a better understanding of the role of the Aboriginal Patient Navigator, learn to use correct terminology, learn about the Aboriginal groups of this province, which I think is very important. It's still quite surprising exactly how many people still do not know who the Aboriginal groups are. Also, be more aware and have a better understanding of the historical, political, and cultural aspects or cultural issues that impact the health of Aboriginal people in this province, and provide patients with a culturally safe healthcare environment. So looking into terminology, Aboriginal versus Indigenous, the two are both accepted. Indigenous is becoming more common, I find, than Aboriginal. I find Indigenous is used more in context. I would say I would never identify myself as being Indigenous. A lot of people from where I come from Labrador, would refer themselves to Aboriginal, and that is a word that I would be more comfortable using. And in regards to First Nations, that is a group that would refer to themselves, would be the Mi'kmaq, the Halapu, the Miapuki First Nation. The word Indians is not used anymore. They do not accept that word, so please remember that do not refer to First Nations as Indians. And Native is not a word that is used as well. As well as the Innu, they prefer to be called Innu instead of, they're recognized as First Nations and Innu. And this one as well, the Inuit, we like to be referred to as Inuit. Inuit means more than one person. I would identify myself as an Inuk, which is just one person. And Eskimo is a no-no. It's a derogatory name. We no longer use that. So please just remember. So the Aboriginal Patient Navigator Program was implemented in 2009 as a pilot project. So the Aboriginal Patient Navigators offers support and assistance to Aboriginal patients and clients who are referred to St. John's for medical treatment. So we're the link between the Aboriginal communities and Eastern healthcare providers. I'd like to just talk about a history of the Aboriginal Patient Navigator Program. There were actually 2 studies done. In 2002, the St. John's Native Friendship Center, along with the Division of Community Health within the Faculty of Medicine at MUN, produced a Building Bridges study. The purpose of this study was to improve experiences for Aboriginal people in the urban healthcare system. From the study came several outcomes. There was a need to ensure the delivery of appropriate care to the province's Aboriginal people, and that these individuals experience a wide range of difficulties in urban healthcare settings. In 2005, a cultural sensitivity report was done. The Cultural Diversity Working Group concluded that effective follow-up care for Aboriginal patients was a concern. And according to the study, informants from Labrador reported that patients were returning home with incomplete information for follow-up care. These 2 reports were the groundwork that would become the base of the APN program. And the needs that were identified, as you can see right here, was language interpretative services, dietary needs, signage, communication, patient education and orientation, and follow-up care. Now I'm going to move on to what we do as Aboriginal patient navigators. One of the things that are very important is navigation to appointments. A lot of patients that come to St. John's have never been to St. John's before. They're coming from small communities. They have language barriers. Then they're coming through to the Health Science Center, main entrance, trying to find their way to their appointments. We mainly deal with patients in acute care, but we also navigate patients to outpatient appointments who also have general surgery appointments. Just to give an example, somebody that's coming for a pre-op, they have to go to x-ray, they have to get blood work done, they have to go to EKG. They need to find the nurse's clinic to speak to the nurse there, wait to speak to anesthesiologist, and coming through the doors of the Health Science Center is a total maze. You don't know where to go. So we will get the call from the liaison workers, just say such as in Goose Bay or from Halapu First Nation. Okay, Katie, we have so-and-so coming. They're very nervous. They have never been to the Health Science Center before. Can you meet them at the main entrance? They have an appointment with a pre-op. So can you take them to the pre-admission clinic, or can you show them where to go to get the colonoscopy on the 4th floor of the Health Science Center? Just trying to find your way is very, very overwhelming for anybody that's coming here to the Health Science Center for the first time. So we will guide them and take them to their appointment. We ask them what they need. Some will just need navigation. How do I get to my appointment? We also have other patients who do not speak English as first language. So they're coming here, they're very confused, they're overwhelmed, and we will guide them to get interpretation if they do not have anybody with them. In most cases, clients that do need an interpreter will have somebody come with them. There may be there may be gaps where such as a patient is coming by air ambulance, and there's no room for the escort to come with the patient. So there's this time frame where the patient will not have an interpreter with them. Just say they're arriving at 6 o'clock at night, and then the escort has to travel by commercial flight, which may not be till the next morning. So there is that gap where they do not have anybody there. We will get the call from the liaison worker and say, okay, so-and-so is being medevaced at 6 o'clock tonight. Can you arrange somebody to be there to meet the client to make sure that the connection is made between the medical staff and the patient until we get the interpreter in the next day or whenever the next flight is available. One of the other things that we do is to access meals, transportation, accommodations for medical clients. Like I said earlier, a lot of our clients are sent in by medevac. So they're coming here not expecting to be here. And I'd just like to share a story of a guy that we had from Labrador. Him and his brother, his brother attempted suicide by hanging. And his brother came home in time, called the medical services. They got him out of Labrador, got to Goose Bay. Goose Bay determined he had to come to the Health Science Center. This happened on a weekend. And by the time they arrived in St. John's, it was 11 o'clock. The escort was actually able to get on the flight because there was room for him on the medical flight. So no connections were made for the escort, for the travel, for the accommodations. So he directly came to St. John's, arrived at 11:30 at night, and this client had no money. He didn't know anybody in St. John's. So he waited out by emergency, just waiting for medical information from his brother. And the next morning, somebody had noticed him and just said, okay, can I help you with something? So they were actually able to connect him with the St. John's Native Friendship Center, say, okay, this person is here. Can you assist him with getting accommodations, meals, transportation? So, and this escort actually came back through our program several years later, and he shared with us his story, and he had wished somebody like our program could have been there for him during that time. So yeah, it's very important for awareness of our program, because a lot of people still don't know that we're here. One of the other things that we do is liaison with internal and external agencies. Every day we communicate with Aboriginal organizations. Like I said earlier, we have liaison workers in Labrador and also as well in Glenwood for Halapu First Nation. So they contact us all the time, say so-and-so is being medevaced out, can you meet up with them? Or they will have somebody that's coming for a follow-up appointment, and can you please make sure this person, they don't know where to go for the appointments, they're confused, can you go and meet with them? So we have a very good relationship with the Aboriginal organizations. And finally, we also do education and information sharing, such as these sessions, providing information and education to clients and families. A lot of times, patients will not understand how procedures are done when they come. They're coming, like I said, they're coming from very small communities, and they don't understand how procedures are done. I remember we had a lady an elderly lady, she was medevaced and she had a fractured femur. On the 4th day, she was still waiting for surgery. Her daughter came to me very upset and said, Katie, why is this happening? I don't know. They said that she would have surgery right away, and this was the 4th day, and she was very upset. And she wanted me to find out why this was happening, so we had to explain to her that there's an emergency priority list that has to go through. And so anyway, she was done finally that day. So we're all very happy about that. So those are some of the things that we do. We are based at the Health Science Center, so we work out of the St. Clair's, the Waterford, the Miller Center, other doctors' offices in the city. We also take clients to the airport. We will get a call from their liaison workers and say, okay, they're very nervous that they've never been to St. John's before. They don't know what to do. They don't know where to go. So sometimes we will meet patients at the airport, or if they're medevaced in, and when they're ready for home, we will go and take them there as well through the airport, through security. True or false? All Aboriginal groups in Newfoundland and Labrador live in Labrador. Obviously you can see the answer there. It is false. When I first started working here back in 2009, I was shocked. Some of the medical staff thought Conn River was actually in Labrador, and that they believed that there are no Aboriginal populations on the island of Newfoundland. So, moving on, I just wanted to talk about the Aboriginal people in our province. So, Innu, the Inuit, the Mi'kmaq, and Nunatuqavut, which refer to themselves as Southern Inuit. So going into Innu, there are two communities. They are located in Natwashish and Sheshashi. They have leaders that are referred to as chiefs and grand chiefs. Their first language is Inuamun, and their second language is English. And there are approximately 1,700 in their communities. And now going to the next is Inuit. There are 5 coastal communities, which is named to Riglet. The population of the Nunatsiavut government is 7,000. The Inuit communities of Nunatsiavut are run by Angayuk, which is an equivalent to a mayor. And the language that is spoken is Inuktitut. It's mainly the seniors that speak the language, the youth and the older. It's mainly seniors that do speak Inuktitut, and English is the other language. Now going on to Mi'kmaq. The Miapuki First Nation Reserve is in Conn River, which is officially designated as Samaji Miapuki Indian Reserve under the Indian Act in 1987. The Halapu Mi'kmaq First Nation Band is previously known as the Federation of Newfoundland Indians. Their leaders are referred to Sagama. The Mi'kmaq are located on the west and south coast portion of the island of Newfoundland. And finally, the Nunatuqavut Inuit. There are a number of communities in Labrador who are represented by Nunatuqavut, which are formerly known as the Labrador Métis Nation. Nunatuqavut means our ancient land. This organization refers to the people as Southern Inuit and are primarily descendants of European and Inuit culture. Nunatuqavut are still in the works of settling Aboriginal land claims agreement with the Canadian courts. What is culture? I know Annette and Molly had touched upon this, but I just thought it was important to include, whether we realize it or not, we are all part of a culture. We carry with us our background, our traditions, our language, our beliefs, and our values, which consists of food we eat, the language we speak, the clothes we wear. Culture is taught and learned and shared. It is generational. What is cultural safety? Cultural safety is a need for people to feel respected and safe when they interact with the healthcare system. Culturally safe healthcare services are free of racism and discrimination and supported using their culture, beliefs, identity, and community. Saul and I had navigated a patient that needed an interpretation. I'm not fluent in my language, so Saul is an interpreter. So we had a patient who required Inuktitut interpretation. So Saul and I both took the patient, and we met with the nurse. She was getting medical history, and she had asked the patient if he had a colonoscopy. So Solomon had asked him, to find out if he had a colonoscopy. So the patient could not understand, obviously, what a colonoscopy was. So he went into detail as best he could to try explain what you do with a colonoscopy. And it took a while, so Saul kept asking questions. The patient and Saul kept communicating back together. And so Saul looked at the nurse, and he said to her, yes, he did have a colonoscopy. And the nurse looked at him very upset and said, it took you that long to get that answer. It was just a tone that she had used. So I just wanted to share that story. Another story that I'd like to share is we had an elderly guy who was actually visually impaired and also illiterate. He went to the doctor, and he told the doctor that his problem, he had hemorrhoids. The doctor handed him a tube of hemorrhoid cream, and just the orders were just to take it twice a day, and that's all that was said. So a couple days later, a neighbor went to visit this patient, and what happened was he just told his neighbor, the cream that I am taking is not working. And what happened there was, when the doctor told him to take it twice a day, he was taking it orally and not applying it to the correct place. So I just wanted to share that story as well. As Molly and Annette touched on the cultural terms as well for cultural safety, cultural awareness refers to the recognition of cultural differences. Cultural sensitivity refers to respecting these differences. Cultural competence refers to the ability to respond appropriately to these differences. And cultural humility is a lifelong process which ensures professionals learn about other cultures and be sensitive to cultural differences. Going on to communication with Aboriginal patients. Some Aboriginal people communicate more with nonverbal cues than verbal exchanges, body language and interpretation. Some Inuit, when asked a question, will answer yes by raising their eyebrows. Shrugging of shoulders, saying, I don't know. Both Innu and Mi'kmaq raise their chin and lips to answer over there. Sorry, I can't demonstrate that one. To answer no to a question, clients will shut their eyes and nod their head. So these are just some of the examples. Going on to possible misconceptions. There are always exceptions, and it's difficult to distinguish sometimes between personality traits and cultural traits. And we don't want to generalize across the Aboriginal board. Every community is unique in its own way. When speaking to an Aboriginal patient, there may be no eye contact with their head down the whole entire conversation. And it is perceived as the patient being rude, non-engaged, or unapproachable. Another one that is very important is answering yes. When you're communicating with an Aboriginal patient, it's common for them to respond yes, even without understanding what is being asked, especially when given instructions on procedures. So please keep in mind when ask them to relay what is being said if there is no interpreter or APN present. Physical appearance. Aboriginals do not always have the typical traits or physical characteristics that most would expect. Looking Aboriginal, dark hair, dark eyes, or eye shape does not mean you grew up a certain way or practice a particular culture. I have a niece that's in her second year of MUN right now. She's got light hair, light skin, green eyes. When she identifies herself as Aboriginal to her peers or to people that she meets, they look at her and they're confused because she does not have dark hair. The Aboriginal patient may not openly share their strengths and accomplishments and may not tell you because they feel it would be breaking. So you'll meet a Aboriginal patient, they're very humble. And you may perceive it as being non-industrious, less involved, or unambitious, or that they're lazy. Another true or false. All Aboriginal groups speak the same language and practice the same traditions. I don't know how many times I've been called by medical staff, by medical staff to come and speak with, to interpret. I'm not an interpreter. And they just don't understand that that they think that we're all just one Aboriginal group. I know I'm cut for time. I'm just going to quickly go into challenges. Within Newfoundland and Labrador, some Aboriginal groups have higher rates of certain conditions, such as diabetes, than others. It is also well known that as a group, there are higher rates of suicide among Aboriginal people. As you know, this doesn't mean that every Aboriginal person will suffer from the same conditions. That is why it's important to treat everyone as an individual. I don't know how many times I've gone to emergency myself, and the first question that comes out of medical staff is, are you diabetic? Which I am not. Challenges continued. Like Molly had touched upon, residential schools, the impact of residential schools. Saul and I, my colleague, had traveled to Truth and Reconciliation events in Fredericton, Moncton, Halifax, Goose Bay, and Hopedale. Our role was to support the residential school survivors who shared their stories. And I remember one family in particular. It was two brothers and their sister, and they were in their late 60s. And at that time, they came up together to tell their stories of what happened to them when they were 6, 7, and 8 years old. And they spoke about losing their language, their culture, loss of sense of community, loss of how to live off the land, and lack of coping mechanisms, and also which resulted in alcohol and drug dependency. Another challenge is traveling. Newfoundland is a geographically vast province. Access to healthcare is therefore challenging because healthcare facilities are not conveniently accessible to many rural, remote communities. Just to say that the main healthcare facility in Goose Bay, and is indicated on the map, and is quite a distance from communities such as Nain. Patients may have to be sent from Labrador Grenfell Health to Goose Bay to St. John's for appointments for procedures that cannot be done in Goose Bay. Just to give an example, the distance from Nain to St. John's is approximately 3,300 kilometers. Just to give a comparison on how 33 kilometers is, it's just like you having to go to Toronto. Imagine you have to travel to Toronto by air ambulance, unable to speak English. You have no interpreter, unable to travel with you due to no room. Have you ever been to Toronto? How do you feel? Overwhelmed? Yes. Moving forward, transportation to and from major healthcare centers and specialists. First of all, Newfoundland weather, which can often cause major issues for traveling. Patients can travel to Goose Bay via Air Borealis. Depending on which community you are from, you can spend up to 6 hours on a Twin Otter to get to and from Labrador Grenfell Health in Goose Bay. This chartered flight is known as the mission flight and will land in several communities on unpaid airstrips to pick up and drop off patients. If patients have to avail of service in St. John's, they have to spend the night in Goose Bay and fly the next day to St. John's, depending on their appointment time. If air travel is not possible, some will drive, which means a long distance on sometimes unpaved roads. Another challenge would be language, Aboriginal language. Many Aboriginal people speak English, some do not, so language barriers can be challenging. For some languages, medical terms is no direct translation to various Aboriginal languages. Just to give an example, Sal is an interpreter. He was asked to go with the patient to interpret for him to give a diagnosis. There's no translation for pancreas. How do you interpret to a patient who has pancreatic cancer? Sal will use body charts and explain the purpose of the organ to help the patient understand the diagnosis. And just a reminder, when speaking to an Aboriginal person, it is common for them to answer yes to questions. So I always ask them to relay back to you what information was shared. I just wanted to share you this story. This little guy, he was medevaced into the Janeway. I had a call one Monday morning to go and meet with him. And when I got upstairs, Mom was gone to get some breakfast. The nurse was trying to just ask the boy if he was hungry. So he looks at the nurse and he just raised his eyebrows. And the nurse said to him, "You're very shy, you're very quiet." And I looked at her and I said, "No, he answered your question." And she looked at me very puzzled. I said, "He raising his eyebrows?" I said, "He means yes. He answered your question. Yes, he's hungry." Challenges continued. Stereotypes. Judgment and stereotypes are prevalent and can sometimes impede relationships and trust building among patients and their healthcare providers. We have somebody that went to visit the emergency. Another situation there was one of the first questions that came out of her mouth, the doctor had asked her if she had trouble with alcohol. I'm almost finished here. Just another story here. Aboriginal elder travels to visit her family in St. John's. She trips and falls before getting into bed and injures her ankle. Her family take her to emergency to be assessed. The doctor asks if she's Aboriginal, asks where she is from, asks how much alcohol she had to drink that night. The woman states that she does not drink alcohol. The doctor said he finds that difficult to believe, considering the community that the woman came from. The elder left emergency without any further assessment. The patient felt disrespected in that the doctor did not believe that she was saying. Was her health jeopardized? Did the doctor provide culturally safe care? What can you do? I'll just run through these very quickly and then I'm done. You can listen, observe, empathize, be accommodating and flexible, be mindful, be respectful, and be humble. Thank you.
Thank you, Katie. Your program certainly offers a lot of very much needed supports and services. I live in St. John's and I find it difficult to navigate the Health Science Center when I'm going for appointments, and I don't have any other of those challenges. So our next presenter, our third presenter for today is Jim Alford, and his presentation is titled Working with Refugees, the Quest for Cultural Competence. So you can come on up, Jim, and I'll get your presentation up. And there you go.
Thank you. Thanks for the opportunity to be here, and really appreciate this actually. This has been a kind of a pet issue of mine for the last several years, and I guess what I wanted to do today was just reflect a little bit on what I know of and what I've learned about and the refugee experience, and both pre and post, and to look at some of the things perhaps we can do to struggle to actualize the concepts of cultural competence and cultural humility. And there's an interesting theme throughout everybody's presentation. We talk about cultural competency being a journey as opposed to a destination. And I called my presentation The Quest because it is a journey. And I would say with some humility that I'm fairly new on that journey myself. And I'm going to speak about my experiences from a mental health context, because that's where my experiences are. And I'm sure some of them can be extrapolated to fit with the larger medical system as well. But I'm going to be honest about my approach in terms of it's primarily mental health focused, and we can extrapolate from that. So it is a quest, it's a journey, and I think it's an important conversation to have, because I work with a lot of people who work with refugee populations, and they're very intimidated by the prospect of working with refugee populations. And in some ways, I'm pleased to see that's because they're afraid of making mistakes. They don't want to offend, they don't want to hurt, they don't want to make things worse. And I think that comes from a place of humility, and I think that's very good, but I also see it act as a barrier and keep us from trying to engage with people that we probably should try and engage with a little more. So that's my experience. So the quest for cultural competence. I'm going to talk a little bit about the refugee experience. And I'm going to do it first from a global context, because I think the global context is particularly important right now. We have right now 68.5 million forcibly displaced people worldwide. And 10 million of them are stateless. They don't hold a passport. They don't have recognition, any real government legitimacy anywhere. A few of them live here, but not many. We have 25.4 million refugees. And those are people that have been forced, displaced people that have left their country of origin. And refugees come from lots of places, but right now, 57% of the refugees come from Syria, Afghanistan, and South Sudan. And we know about the conflict in Afghanistan and Syria, and the conditions have led to the refugee crisis there. And other countries include the Lake Chad Basin in Central Africa, Nigeria, Cameroon, Niger, Chad, Congo, other places as well. So worldwide, there are probably more refugees now than there were in the Second World War. If you look at the population of displaced people, that's far greater than the population of Canada. I think the stats is that it would be the 26th largest country in the world if we had all refugees living together. So this is a worldwide crisis. It's also a crisis that's been politicized and in a very nasty way in the last few years. So it's quite important to get the global context. And just to think about that. And then we're going to just talk a little bit about the local numbers. We go from 68 million to, if we look, last year in Newfoundland until September, because there's no stats I can get after that, there were 167 guards or government-assisted refugees. In 2017, there were 178. In 2016, there were 275 government-assisted refugees. So the numbers are very small in Newfoundland, actually. And there are also privately sponsored refugees. And there was a large number of private sponsored refugees in 2016. So we have small numbers. We get very few asylum seekers in Newfoundland. We used to. When the Russian planes landed here, everybody was getting off the plane in Gander. That doesn't happen anymore. So we get asylum seekers where there's a border. There's no real border to Newfoundland, so we don't get very many. And the highest numbers here are from Syria, but there's a large number from Eritrea, and Congo and Sudan are also well represented in those numbers. So that's the refugees we're getting here. This population is part of you might have 1,200 immigrants to Newfoundland every year. So if you think about it, we do have, we have a small population. There are more people coming, but we're not dealing with huge numbers. But you can see it significant change in the population. You can notice it in the East End of St. John's. It's a wonderful thing. The diversity that brings, I think, is such a positive thing for this province. So the impact of this, we have a slowly growing former refugee and immigrant population, especially in St. John's. The other impact is sometimes difficult to get people to stay here because of employment issues or if they're not part of a larger cultural community. So people will leave because there's a large community in Calgary or they can't get work. So our problem actually is getting the refugees that come here to stay and the immigrants to come here to stay. We are no way experiencing a refugee crisis in this province. We are experiencing a refugee crisis in Jordan, in Turkey, and lots of countries that are unable to provide the basic things that you need to live and adjust. We're not experiencing that here. Has healthcare been impacted? Has mental health been impacted? Yes, some, but we have the capacity to absorb, if we choose to, any of the refugee populations, and we could absorb a good many more if we put a few more resources in there. So we're not having a crisis. So if you hear that on the news or on the open line, that's just simply untrue. So make a statement about that. So we're not experiencing a crisis. Refugee experiences can be far different than other immigrants, and that's what I'm going to talk about. There's certainly a locus of control. If you're an immigrant and you move, that's your choice. As a refugee, you may not have your choice where you're going, and that's a far different experience. And what's really important to think about as I give this presentation talking about, I'm generalizing experiences. Everybody's experience is different. Really important to know that. So the refugee experience, we're talking about people that are coming here for some very good reasons because of persecution and conflict, generalized violence, human rights violations, and often people have experienced trauma. And the trauma has often been quite severe. So we talk about trauma, so I'll just use the brief definition, a psychologically distressing event outside the range of usual human experience, okay? Distressing to almost everyone and usually experienced with intense fear, terror, and helplessness. Serious threat to one's life or physical integrity, serious threat to one's children, spouse or relative or friends, sudden destruction of one's home or community. These are the kinds of trauma events you probably will see or hear about if you know refugees. Seeing another person who's been killed or seriously injured as a result of accident or physical violence. So those are the kinds of things that people are often bringing in their experience. So we know what the trauma impacts are. We know there's psychological and emotional health, there's physical health, there's some intergenerational experiences of trauma that we know about. It has an impact on community, on society, culture. Impacts are interreactive and multidirectional and has an impact on historical space. And what I mean by that, it has an impact on how you see the world, both in terms of the history and going forward. So that's the kind of cultural impact. So that's some of the trauma impacts we see. We know that there are, geez, what did I just do? I shut it off. Okay. Don't want to do that. We know that impacts are from pre-migration experiences, displacement, human rights abuses, life events, and pre-existing mental health issues are all pre-migration experiences that impact on integration. We have migration factors. Where you came from, the route and direction, exposure to harsh living conditions, disruption of family and community networks, uncertainty of outcomes, and exposure to violence. And you will hear horror stories about the migration experience, sometimes greater than the pre-migration experience. And then we have post-migration factors, and this is where we can have some impact, because the post-migration factors, people might be relieving traumatic life events, they may be having a difficult acculturation experience, and as health providers, we can do our best when we meet them to help with that. They may be experiencing racism and discrimination. We have lots of examples of racism and discrimination, and in lots of ways it's been so politicized that it's become almost well, it's just far too legitimate than it should be. There can be other social problems in the host nation, and one of the big post-migration factors that has an impact is continued unsafe conditions for family and friends in the country of origin. One of the wonderful things we have that refugees have access to now is everybody in the world owns a cell phone, and everybody has contact, and everybody has the internet, and they're able to do that. But if you have family living on continued unsafe environments, I think that brings it even closer. So those are some of the things you may see if you're dealing with a refugee population. So we have differences for women refugees, and what we see, and because it needs to be noted, the experiences are very different for men, women, and children. And women refugees are more likely to be affected, obviously, by gender-based violence than any other women's population in the world, okay? So that's who you're likely to see. Since World War II, there's been systematic rape of women and girls has been used as an instrument of war, and ethnic cleansing, and women refugees remain vulnerable to exploitation even as they flee, and their vulnerability can continue once they enter countries of asylum. So there's a real vulnerability you see in women refugees, and we need to consider that as well. Interesting, I'll talk about children and youth, but we talked about indigenous people, and if you look at war-torn countries, you look at any of the histories there, the populations most likely to be displaced are indigenous populations. And so the double whammy with that for sure. Children and youth refugees. So I'm going to read something from the UN in 1996. Armed conflict and other forms of organized violence destabilize the very foundation of children's lives, disintegrating families, breaking down communities, destroying trust among people, and interrupting education and health services. Most refugee children endure an incredible amount of stress and hardship that can affect their emotional, cognitive, social development, increase risk of developing mental health problems. So that's the bad news. The good news, actually, about both women and children in terms of the response is, and I'll say this, despite the risk, many children show profound strength and resilience in their ability to overcome difficult situations and adapt to new environments. Many children who have experienced war and political violence manage to have relatively good mental health. This is a paradox, and it's the refugee population, a paradox. If you're working with this population, it tends to blow you out of the water a little bit. And you see people who've experienced horrific experiences may be really experiencing trauma, but still in other parts of their lives are doing really well. I'm not sure what the secret is to that paradox. But in lots of ways, it's interesting when you see that horrible experiences are not held as much as event central in their lives. It's kind of my read on it, and I think, you know, the whole process of going somewhere new, starting something new, and you're so busy with living your life, it's hard to keep horror as event central. Not that it doesn't happen, but it really is a little paradox. You'd think you'd see more trauma than you actually do, but you don't. So one of the things, so these are some of the experiences refugee people are bringing. So we've looked at some of the risk and experience. The actual experiences are very varied. We can't make assumptions. We don't know. And I talk a little bit, you know, using that trauma-informed care lens, which means you might assume that there is, but you don't know that there is. So you treat everybody in the same way, recognizing many people may have experienced difficult situations, but not everybody has. A little cultural knowledge can be a dangerous thing sometimes, and I guess don't make assumptions. Go in with the idea of humility is such a better concept for me. I don't know, I'm going to ask, I'm trying to do my best to understand and experience, but you know, it's easy to make mistakes. It's easy to think, okay, somebody's from somewhere, then they must behave like this, or this is important to them. You never quite know. People sometimes, even from the very same region, or country share very little culturally with others from the same areas. You get people from come from the same geographic location, they have different religious contexts, they have different spiritual contexts, they have different cultural contexts altogether, and that's very easy to get yourself trapped by making assumptions. You know, people from the same country do not necessarily share the same culture. Okay, so refugee is not an identity. I'm speaking about the refugee population, but the refugee population does not identity as the refugee population. They identify as people from Syria, from Iraq, from the Congo. They identify as Iraqi Canadians. And when you get here, you stop being a refugee. It's the refugee experience that you bring. You are a new Canadian when you get here. And it's important to understand the history so you can give appropriate treatment and response, but you are helping people really build and develop and belong in a new place. So I think that's really, really important. So it's not an identity. So we have to be careful about that. We can't make assumptions. So, and as I said before, the refugee story may or may not be event central to their lives. And people are often very future focused. Adaptation and resilience and strength is often what you notice. And the other thing is many refugee clients and patients have very good physical and mental health when they get there. So that's the thing. We can't make assumptions, but we need to be aware. Resilience is one of the things that, again, I'll go back to, an adaptive response to an extraordinary challenge, a process about bouncing back, and a resumption of healthy functioning. So that's important. You see post-traumatic growth. Have to be careful about that. We don't want to identify it when it's not there. We don't want to make it an expectation, but we do see post-traumatic growth in refugee populations. At the same time, you see post-traumatic stress. They are mutually exclusive. They happen at the same time. So that's really changes in relationship and philosophy and new possibilities. So responses that are sensitive, principles of trust, respect for diversity, equity, fairness, and social justice. We need to take our social justice lens with us if we're working with this population, and be aware of more than the surface culture, which we can see, but recognize we all have unspoken rules around behavior and unconscious rules, which we're not very aware of on our own. So we need to dig deep. It's more about the food and the clothing. It's more about even the songs and the dancing. It's about what those things mean, how they're interpreted, and we need to examine our own as well as be curious about others. And I think that's really important. The other thing is cultures intersect and evolve. Work with families. You have different people that hold on to different parts of a culture differently in families, and you have intersections. Rob's going to be talking about LGBT youth, and I often see refugees that come, and they may have, you have a culture that's transmitted down, intersecting with a culture of who you are becoming or who you are yourself. So it's really, really interesting. So it's really about being curious and humble and respect for the diverse and the universal, because we are different, but there are universal as human beings we hold, and I think that kind of respect for both, and challenging our own assumptions and challenging our own, I guess, corporate assumptions where we work as well, and need to be looking at how we can put up barriers to people and what we can do to take those down. I'm going to go through that, just some of the things we really need to be thinking about as clinicians. Not there's anything radical in this, but we need to be really looking at responding with empathy and using perspective taking, staying out of judgment, recognizing what's going on with people and respond. We need to be looking at using trauma informed care. We need to look at traditional healing. and what people bring and what they believe in wellness and health. And that's been said 2 or 3 times, but it's important to explore the person's preferred type of intervention. It's helpful to learn and perhaps integrate traditional healing approaches. And examples are culturally relevant ceremonies, but require us to work to understand the beliefs and attitudes behind the ceremonies as well as the surface stuff. So work and learn and explore and be respectful of what people bring in terms of how they see their own healing. And that process of self-healing, the social instruments of healing, altruism, work and school, and spirituality. So we work to help people, find a sense of belonging, and we help people, develop their own sense of altruism. And we look at spirituality and healing as well. And we need to be more open to the role with immigrant and refugee populations. And the religious and spiritual factors are often important in how people approach and understand healing. Not necessarily so, but they can be. And it's not about our beliefs and practices, but is respecting and helping others utilize their beliefs, and just being open to the learning, to be open to making mistakes, and be open to having the courage to try and connect with people and work beyond the more probably surface barriers to connecting with people on a level where there's something that can develop. It's an immensely rewarding experience. So thank you.
Thank you very much, Jim. I think cultural humility is something that we can all, work towards practicing more in our professions. I am to welcome our final panelist presenter for today. It's Rob Sinnott. And so you can come on up, and I'll get your presentation up for you. If I can find my mouse. And welcome, Rob.
Thank you. Okay. Let me get organized here. Thanks for your attention on this afternoon, and maybe I'll adjust this. People can hear me okay? Okay. Thank you to the NLASW and the ARNNL for the invite. I appreciate that. And I want to acknowledge that a few of these slides came from a previous presentation that I developed with Dr. Mary Lynn Sinnott, no relation. She's a family physician here in town. And I also want to begin by acknowledging that while I identify as part of this population, the LGBTQ plus population, I do not have the lived experience of all people within this group, because I think that that's important to acknowledge. As I prepared for this talk, I had some thoughts about what will I say, how will I word it, will I make a mistake in what I say? And I think it really normalizes what a lot of us feel in terms of cultural competence work, because we want to do well, we want to be respectful. And I think the key is openness to dialogue and learning, and being open to feedback is important. Okay. I know how to use the clicker. I wanted to highlight one of the standards from the Cultural Competence and Social Work Practice. Social workers engage in continuing professional development to foster knowledge, skills, and abilities. Thank you for your help. In working with clients from diverse cultural backgrounds. Okay. Can people hear me okay now? Okay. So, that is a critical piece, it's a professional development opportunities like today. So why is cultural competence important? It's about adopting a diversity lens versus a hetero and cis-normative approach to care. So hetero is reference to heterosexual, so considering relationships in terms of between men and women. And cis-normative would be referring to the assumption that people are cisgender. So cisgender means that you have a gender identity that aligns with the gender that you were assigned at birth. So, you know, it's about understanding that we are working with LGBTQ people all the time, even when we assume that we're not. And a cultural competence framework helps us move beyond clinical competence. So for example, in my world of counseling, we can be very competent in the use of approaches like CBT or DBT, solution-focused therapy. And cultural competence is adding on that piece of understanding the other. It includes knowledge about the impacts of oppression, so recognizing that LGBTQ people can have higher rates of mental health issues like depression, anxiety, suicidality, substance use, because of the experience of discrimination. And it also involves moving beyond a competent enough approach. So the idea is that it's not enough to attend one event or to read a certain number of articles, and that the learning is ongoing, as we've all been talking about. And cultural competence may help reduce health disparities. Many LGBTQ people avoid seeking care or fear seeking care because of the response that they'll receive from the provider. So providers, agencies, and whole communities becoming culturally competent can help reduce disparities. All right. So the gender unicorn. Are people familiar with this? Yeah. It's a neat little infographic to help understand the diversity of identity and aspects of ourselves. And it's a resource from the Trans Student Educational Resources. You can check it out online for more information. But in terms of gender identity, we're talking about our internal sense of being male, female, both, somewhere else on the spectrum, or some people may not identify with any gender. So it goes beyond what we call the binaries of male and female. So there's great diversity in gender identity, much more than perhaps people realize. Gender expression refers to how we express ourselves. So it's through our appearance, our dress, our behavior. Socially, we view expression as masculine, feminine, or gender neutral. Sex assigned at birth, we're all assigned a sex at birth. And again, some people may come to know themselves and their gender identity as differing from their sex assigned at birth. Sexual attraction recognizes that we may have an attraction to people sexually or we may not. And there's great diversity in that. When we speak of sexual orientation, we're talking about terms like gay, lesbian, bisexual. We don't have the time to go through the diversity of identities and terms. There's quite a lot of terms and identities, but there's many examples of glossaries that can provide information on that. Romantic and emotional attraction recognizes that some people may not have a sexual attraction to people, or they may have more of a primary emotional or romantic attraction to people. So that's important to recognize as well. The one thing that I would critique on this slide is the use of the word other. For me, I would prefer additional, because the word other has been critiqued, coming from anyone with a background in feminism, the concept of othering. So additional can be helpful. Okay. So I'm going to keep track of time too. So in terms of cultural competence, from my review of the materials, there are some key areas to consider, including attitudes, knowledge, and skills. So these are some of the areas that we're going to look at. So attitudes is the first piece, and it's a quote from Pema Chodron. The most fundamental harm we can do to ourselves is to remain ignorant by not having the courage and the respect to look at ourselves honestly and gently. And I think that those two words are the key, is honestly and gently, to be patient and kind to ourselves in our learning. Okay. So standard number 2 from the Standards for Cultural Competence in social work practice: social workers recognize and appreciate the importance of being aware of one's own cultural identity and experiences in cross-cultural practice. So that piece of how we bring ourselves to practice and really reflecting on our own experience and our interaction with the people that we work with. These authors have a really useful framework for developing self-awareness. I found it helpful. And the first piece is to self-reflect on our own gender identity, gender expression, sexual or romantic orientation, including development, influences, and experiences. So it's a lot to consider even in that piece of awareness. And that self-examination piece is a key part of our work, and it ties in with the concept of cultural humility, so that ongoing reflection and learning. And then in this model, it invites us to reflect upon our previous contact with LGBTQ plus folks, both personally and professionally, and then to evaluate our reaction to LGBTQ folks, both positively and negatively. So checking in with ourselves and thinking about our responses. The next aspect is to self-evaluate our thoughts, feelings, and behaviors and our responses to LGBTQ plus folks, to develop awareness of potential bi, homo, transphobia, prejudices, and bi, homo, trans negativity. So to really kind of check in with ourselves, to ask questions such as, is there discomfort? Are there judgments showing up? What kind of statements or beliefs am I sharing with others? And then another aspect of this awareness model is to participate in personal and professional activities that foster a greater understanding of LGBTQ plus folks and cultural competence. So opportunities like today, 20 minutes is, the condensed version of cultural competence, but so seeking opportunities like this is really important. The next aspect is knowledge. A quote from Maya Angelou: "I did then what I knew how to do. Now that I know better, I do better." And I think that that's a lovely quote. So becoming culturally competent involves taking initiatives to learn. Sometimes LGBTQ folks will talk about how they feel a burden to educate people or their providers. So we learn from people, yes, but we also have responsibility for our own learning. There are many opportunities for learning, which I'll talk about in a minute. Again, familiarizing ourselves with language and terms, which can vary over time. I frequently have to refer back to glossaries, or someone will mention a term and I haven't heard it in a while, or I need educating as well. So things are always developing, and developing from the community, which is quite powerful. Becoming culturally competent involves understanding human rights and policies. Understanding the impacts of oppression and approaches to coming out, recognizing that coming out is an individual journey. Transitioning is sometimes language used in work with trans folks. So to consider, what kind of supports were or are available to people, respecting people's own pace in coming out if they choose to, recognizing some people choose not to. Knowing community resources, I'm delighted that over the years there have been quite a growth in support groups and often volunteer-driven. In fact, I have a resource that's 3 pages of local community resources. So if anybody wants that after today's talk, they're welcome to contact me, and I'll find a way to upload that as well. We need to consider the intersections of identities or social locations, as previously mentioned by the other presenters. So to consider differences like disability, race, to consider a person's country of origin or language. You know, an example that I have is that Eastern Health has interpretation services available. So if you're working with someone whose primary language is not English, having access to that is a way of considering intersections. I know that there's great diversity within the population. So there's many forms of learning. Biographies, novels, documentaries or films, videos. I find there's lots of resources on YouTube from credible sources. Internet, blogs, books. This is a picture of an awesome book that I found really helpful called Trans Bodies, Trans Selves, written by and for trans people. And they're working on a second version coming out soon. Journal articles. There was a recent issue from the Canadian Medical Association journal that is focused on work with trans people, as an example. Growth of literature over the years as well. And I really appreciate looking at research that focuses on LGBTQ people, but also research that focuses on trans people only, so that we really know and appreciate the experience of trans people, and that, you know, that is important. Attending panels could be another way of learning, having conversations with LGBTQ plus people through our work, through our friendships, our colleagues, you know, learning about people's lives and experiences when it's appropriate. Okay. So we can observe or debrief following sessions, with the caution that in terms of observation, always ask for permission, and to know that not everyone would be comfortable with that. To engage in consultation and supervision, including with experienced providers. I know I'm always open to consultations. Developing a network of providers or community of practice. Here in Eastern Health, we in 2011, we developed a network of providers in relation to trans health. It's now called the Trans Health Committee of Eastern Health. And we've been looking at developing capacity in the area of trans health with a particular emphasis on a series of education events over the years. Okay. So keeping up with the ever-evolving language and the grassroots social movement, attending seminars and conferences, having a working knowledge of clinical guidelines such as the World Professional Association of Transgender Health Standards of Care. This is the trans pride flag, by the way. And there are other examples of guidelines as well. For example, the APA, the American Psychological Association, has guidelines in terms of work with trans and gender diverse people, and also practice with lesbian, gay, and bisexual people. Okay. So human rights and policies. So having an understanding of our history, which, you know, in terms of our rights as LGBTQ people have been fairly recent when we consider it. Sexual activity between people of similar sex or gender was decriminalized in Canada in 1969. There are still over 70 countries, unfortunately, in the world where sex is still decriminalized. I mean, it's still criminalized. In some countries, there is a death penalty. So having an understanding of where people come from and what their experience might be would be important. The Canadian Human Rights Act added sexual orientation as a protected ground of discrimination in 1996. The Newfoundland and Labrador Human Rights Act added sexual orientation as a protected ground in 1997. The Newfoundland and Labrador Human Rights Act added gender identity and gender expression in 2013, and the Canadian Human Rights Act added gender identity and gender expression in 2017. So very recent history that the rights of people have been protected.